Thank you very much for being here. And any intensive care professor who is making a talk with the evolution and enterprise does not omit to start with the Copenhagen pandemics with polio. And then some of my colleagues said, oh my God, we are having it again. But I will not do the classical talk about that, but I will give you some interesting information. For those who have not seen it, because we are 50% physicians and 50% not, these were the mechanical ventilators, something called iron tank that you put the patient in and you thought that he was being ventilated. He was not. But the important issue here is that in those years they had some equipment that we actually didn't know that they had it. For example, they could measure the acid-base disturbances of the patients in laboratory settings, but they were not using it really in the clinics until that time. This one is the Van Slijk's method. It was used at the terminal stage of polio patients, and then they suddenly realized that the patients were completely alkalotic. And the explanation was, if you have enough virus in your blood, you become alkalotic. And that's why your carbon dioxide is raising up. For those who are not from our profession, I mean, at that time it was obvious for Ibsen that it was the other way around. He was also called in 1952, when anesthesiology was not considered to be a medical profession really, because a couple of months ago, his wife was traveling from America to Denmark with the second commander-in-chief of the hospital, who were all extremely hopeless to take care of these patients. And he said, let's call the Ibsen. He has some experience on this. And somebody said, we cannot call anesthesiologist for that. I mean, it's a little bit of a shame. But in the end, they were convinced. And he came and asked, why are the patients cyanotic? Why are they completely blue in the face? And somebody said, that's how it is with polio. If there is enough virus in your brain, you become blue. That was also indirectly correct, actually, because that was actually the result that you had. Now, there were two different machines there. One of them is the Carbovisor of Brinkmann. This was used to measure expiratory carbon dioxide. Anesthesiologists were using it every now and then. But the other one is also very interesting. You see a huge thing, actually, as big as half of my hand and quite heavy. This was an oximeter. The oximeter was not used for patient care. The oximeter was used for the first time in 1942 to measure the oxygen saturation of the pilots during the war when they were flying high, to see how dangerous it was to fly in the heights. So Ibsen has used these machines, and I must say, if you see the oximeter, probably after such a long flight, the pilots would have an ear hanging on one side, because it was not easy to have it for many hours. So Ibsen has used this and showed that if you ventilate the patients properly on your hand, you will reduce the carbon dioxide of the patients at experium. I mean, these are the figures that you can see everywhere, but the important thing was the mortality was almost 90% and it was reduced to 25%. Well, if you see the polio units originating the first intensive care beds, it was later extrapolated to other patients with respiratory failure, with higher nurse-to-patient ratio, and at a certain moment the intensive care was born. This is an old picture of University Medical Center Utrecht, our old intensive care unit, and if you really carefully look, one of the nurses that you see there is also sitting among us and looking at me at this very moment. So I go back to Turkey, because 52 Copenhagen, 59 in Turkey. It was the first time in '59 that the name intensive care was added to the diploma of anesthesiology. Dr. Cemalettin Öner, you see his picture there, he was the first intensivist of Turkey. And he has founded the first intensive care bed of 20 beds in Istanbul. Later, in 1970, he came to the University of Istanbul, where I was trained, and he opened the intensive care medicine, and he had his academic title. I started my training 10 years afterwards, and I was a trainee of him. And when I was in the department, that was my second day, they were taking me around. Suddenly, at that moment when I was in intensive care, there was a organophosphate intoxication patient coming in. Organophosphate does not exist anymore. It was at that time for the industrial use to kill the unnecessary insects, let's say. Organophosphate intoxication has muscarinic and nicotinic signs, and it's very, very complicated. You have to be very quick. You need a teamwork. I have seen the people working there and stabilizing the patient. And at that time, I already thought that this is a decisive moment for me. This is what I want to become. But an interesting statistics, Istanbul was 4.5 million population in 1980. And if you look at the 30 beds that we had, it was 0.67 beds for a population of 100,000 people. So it's, I think, very clear that initially I learned more triaging the patients rather than treating the intensive care patients. During the early days, intensive care was a symptomatic treatment. We were keeping the patients alive by taking care that their respiration was okay, maintaining the respiration and circulation, and for the rest we needed other specialities, each covering their own field. And this was an excellent example of fragmented treatment of a patient. Treatment not as a patient, but as an organ. This led to different ICUs in one organization run by different specialities. The protocols of treatment were different. The algorithm was different. A person working in one ICU could not work in the other one because they didn't have the knowledge. There were very good care for the organs. In a cardiologist's intensive care, the heart was taken care excellently. But there was not much affinity for other treatments outside the expert knowledge. If you look at the trend today, you will see that most of the specialities are focusing. We don't have general surgeons, we don't have general internists anymore, while this is happening the other way around in intensive care. We are maintaining our generalistic approach in order to have enough knowledge of the whole patient so that we have the broad knowledge and competencies to treat the patient as a whole and not as an organ. European Society of Intensive Care Medicine already defined around 15 years ago the international competency-based training in intensive care medicine, which was called COBATRIS. Many countries have adopted this. Also Netherlands, with some changes, this was adopted. And this is now a part of the training in many European countries. We have come to a point, actually, that intensivists routinely perform continuous veno-venous hemofiltration, that's dialysis, ultrasound, ECMO, bronchoscopy, feeding, antibiotics, and many other treatments in our daily practice. And there is growing insight the last 15 to 20 years next to the mental next to the physical well-being, to the mental well-being of patients and their families, and also for their long-term outcomes. Intensive care medicine, ladies and gentlemen, has become a unique multidisciplinary profession, clearly transcending many other specialisms. And I can easily state that considering these developments, at present there is no other speciality which is in state of considering themselves as naturally competent to carry the responsibility of an intensive care unit. As I said, the competencies have great diversity now. The days are gone that a good intubation skill or putting a good central venous line is equivalent to being a good intensivist, and that makes it too big to be a part of a classical specialty, whatever that may be. I have taken this from Ashish Khanna and Louis Kaplan. Louis Kaplan was the president of Society of Critical Care Medicine at the same time when I was the president of European Society of Intensive Care Medicine. And he's also a very good friend. And they have defined the ideal intensivist as the person who has the keen observation of a pediatrician, as the patients can't talk. The patience of an obstetrician for watchful waiting. The thoughtfulness of a physician, they mean an internal medicine specialist. Multiple complex problems which need sorting. The rapid reflexes of an anesthesiologist. The aggressiveness of a surgeon, when definite intervention is needed, the communication skills of a psychiatrist, families and friends need counseling, and it was my addition as the last one that the diplomatic skills of Secretary General of United Nations, with the interaction of multiple specialities, each one of them having their agendas. I'm happy that this has been done in the Netherlands already for almost 20 years, that intensive care has a clear presence in the organogram of the hospital. It is an independent department, 24/7 dedicated personnel working for intensive care, and the budget dedicated to intensive care department. This way, the management of intensive care, the quality of care, the training and coordination with other divisions with the hospital will be solved with well-established intensive care organization. It was 2006, the last days of September, if I remember correctly. Our management team was in Laren, and we were talking, four of us, about the future that we wanted to go. And at the end of the day, this statement has come out. It is the organization which saves the lives of the patients. In 2004, the board of directors of University Medical Center Utrecht, chaired by Professor Geert Blijham, I can proudly say that he is with us today, I'm very happy for that, has decided to form a multidisciplinary intensive care unit. The job was given to Margriet Snyder, also proudly mentioning that she is here as the chair of the board of directors of University Medical Center Utrecht. Afin Sprey, she is here, and Bert Koster, he is here. And we had exciting, challenging, demanding, and confronting years. At the end, a state-of-the-art ICU featured with top care, and today even more than the top care that we had reached at that time, of the family, patient, well-being of the personnel, and the, last but not least, award-winning architecture. That was the result we have achieved. Our concept was visited by many people from almost from every continent. We had people from Asia, we have people from North and South America. The most striking one actually was the lady who came from Australia, an intensivist associate professor, Teresa Jacques from Sydney. She came to Utrecht, visited us for 3 hours, and then went back to Australia. An interesting issue is that I was last month in Tianjin in China, and I was actually having only 2 presentations there, but I had 9 business meetings with academic leaders of 9 academic hospitals. They were asking for information about certain ways of medical handling, but that was for me, I mean, reserved for me. It was only a small percentage of their question. Every single one of them, at the end, they were coming and spending most of the time asking about the organization of intensive care. And it was about multidisciplinary versus specialized, because China is mostly specialized ICU. And when I was talking with them, independent of which center it was, because they were coming one by one, not all together, the problems that we had here, or the ideas that we had here, they were all existing there almost identically. I would like to take a moment to name the 3 visionaries. Professor Chris Stoutenbeck, with whom I had the privilege of having worked for a couple of years in the same department. Professor Bert Thijs, I had the privilege of working with him, not in the clinical grounds, but in commissions and other situations. And Professor Kees van der Linden, they found the Joint Commission of Intensivists in the Netherlands. The anterograde training of the intensivists started shortly afterwards in the Netherlands, and Kik was, the Joint Commission of Intensivists, was representing the primary specialities. This has actually led a competency-based training and developed to a very high quality during the last 30 years. And I would like to tell you the name of Professor Arman Kirby, especially. Also here, I'm happy to see him, because in his chairmanship time, the mandate of Joint Commission of Intensivists were strongly consolidated. It is very often discussed whether intensive care should be a separate specialty or not. And when you are in your hotel room in Utrecht, you see a lot of buildings with 30 floors. And then I can say, which one of us actually thinks of starting the building the 30th floor? We all begin from the fundaments, right? A building can stay strong if you have a good fundaments. So actually, intensive care as a primary specialty is not a discussion to begin with, but it is the result of a whole evolution and enterprise. It's built up slowly. But having said that, I can clearly say that Netherlands belongs to the group of countries where the fundamentals of intensive care are very, 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 very strong. I will come to technical things with the coming 2 or 3 slides, because actually, after mechanical ventilation started, we realized that we had to leave a few centimeters of water of pressure in your lungs in order to keep the lungs open. And this was called positive end expiratory pressure. The positive end expiratory pressure, PEEP, has been used and misused in intensive care patients for many, many years. One example is here, a publication from 1975 in Chest. A level of PEEP up to 44 centimeters of water were used, and to give a tidal volume of 1 liter, 160 centimeters of inspiration pressure was used with the patients. Apparently, cardiac output was not affected. We have here a few very prominent heart specialists from the world. Maybe you can explain to me later how did this happen. But somehow some patients had pneumothorax, clap lung. Oh, okay. When I go back to Istanbul, when I started, we had these 2 manometric ventilators. They were not time cycled. You were putting the pressure there, and according to the quality of the lung, sometimes the tidal volume was a bit bigger, but if the lung was very bad in quality, you could give a very small volume, and then the expiration started. We couldn't measure the blood gas because we had a pH meter. It worked usually 20 days, and after 20 days the electrode was not working anymore, so we were ordering it to Copenhagen. It took 20 days to come, so it was 20 days with, 20 days without. You know what? It worked. There was no big problems. The problems began when we had volumetric mechanical ventilators where you could give as much as PEEP as you want and as much as volume that you wanted. We didn't have possibility to give PEEP with these machines, but I have later, with my communication, realized that there was international way of solving the situation, that you put a tubing in the experium and you put the tube in water. If you put 10 centimeters in water, it was 10 centimeters of PEEP. Now, when I was talking many years ago, some of you will still remember Roger Bone. He was in Vietnam as a physician, and he said they were doing the same thing. And last February, I was in Pontresina with Peter Suter, who is the founder of our society, of European Society of Intensive Care Medicine. He was also doing that. Now, we had in Istanbul a good luck because our container was not very deep, so we couldn't give excessive amounts of PEEP, and that was a good clinical situation for us. Professor Burkhard Lachmann, he is with us today. He is my promoter, my mentor. I've learned everything from mechanical ventilation from him. I just want to mention that he has defined for the first time the pressure-controlled time-cycled ventilation. He has shown that with prolonged inspiration time, we could improve the oxygenation while preventing barotrauma to the low delta PEEP we used. At that time, we defined delta PEEP as the plateau pressure minus PEEP. And recently, I think some 8 years ago, this was defined as the driving pressure that we are using now. And it was seen, as one of the speakers mentioned yesterday, to be correlated with increased survival. I would like to be a little bit challenging, but the good news is that you will not be answering me anyway, even if you don't agree with me. ICU is a semi-autonomous mini-hospital. Patient data management system is a primary system for nurses and physicians in the intensive care setting. And a patient data management system which is eligible to be used in ICU will be eligible to be used anywhere in the hospital. It was in 2016, I was in London giving a talk on medication safety. I had two good friends, Hans Flaten from Norway and Andreas Valentin from Austria. They have criticized me because we had two different systems in our hospital. They said this is impossible, you should never have two different systems. I tried to explain them that two systems were communicating with each other properly, and I said, hospital system is not adequate to be used in ICU, and to upgrade it is stagnating at that time. Can't say that it's not stagnating now, but at that time we are talking of 2016. So Andreas' answer was crystal clear because he said, in my hospital, a system like this is first tested in the ICU. It is only bought if it is eligible for the ICU. Then instead of trying to upgrade it to ICU, then we try to downgrade it to the rest of the hospital. I would like to make a link to the ethical aspects of life-sustaining treatments in intensive care. I mean, I don't have to tell it to all of you. You all know, whether physicians or not, that the modern technology, we can support the lives of the patients, of some patients, indefinitely. And sometimes we keep the patients indefinitely alive, even if there is no hope for a cure. This was seen in 1957 already by Dr. Bruno Heid from Austria, and he observed exactly what I said. They were saved from death, but they were not getting better. So medical staff and their families were completely confused because they didn't know what to do. Should the mechanical ventilation be stopped or not? Who would decide on it? Who would perform it? And Dr. Hyde could not find adequate guidance from the medical world. He has done something that we probably today would not think of doing it. He asked it to the religious authorities for help. He submitted more than few questions to Pope Pius XII on medical moral regarding such treatment. I took only 2 of the questions that he said. There are more questions. You can find it in internet. It's very interesting. But the first question that I took over was, does the physician have the right, or is he obliged, to use modern equipments, even in certain cases, the doctor's judgment, the patient is completely hopeless? Do we have to do it? And the second one is, do we have the right, or are we obliged to remove the life-supporting therapies if we know that the patient has no chance to recover? Well, Pope was a little bit troubled at that time from these questions because he didn't have the knowledge, but he said, I will try. He tried. He had an answer. And he convened an international congress of anesthesiologists. And subsequently, he declared that neither the physicians nor the families were obliged to continue aggressive treatment for those patients who had no hope of recovery, and the prognosis was death. And in his opinion, the withdrawal of life-sustaining treatment was morally acceptable. I'm sure you are also asking, 66 years later, whether any religious authority would be daring today to make such a statement. I leave the answer to you. But we are still today having these similar uncertainties concerning many issues in ethical situation, and these concerns exist worldwide. Theoretically, if you ask to intensivists, you will hardly have a lot of people who would say we have to continue the treatment indefinitely. And you will hear that only patients who have a chance of survival should be treated in intensive care units. In practice, this is different. We also know that. In practice, there are huge deviations from this concept, deviations between the countries, but the deviations within the countries, and sometimes within the same hospital. I would like to have your attention about the multicultural characteristics of Europe. Is becoming now more and more prominent. This is the case for Netherlands as well, but we are not very unique in that. The last years, it's not very uncommon that we have conflicts with the families of the patients when we want to, for example, stop the treatment and start with palliative care, especially with families from various cultures and religions. In the Dutch culture, the majority of the families would accept withholding or withdrawing the treatment and starting the palliative care if either no benefit is accepted or the quality of life to be achieved will not be at a level of dignified life. This is different in other cultures and religions because many of them would like to be going on with the treatment, whatever the costs are, irrespective of the results which can be achieved. At the moment, actually, we don't have a tailored system. We don't have a healthy ethical end of life procedure to address the needs of different cultures and different religions. And that makes actually the physicians and the nurses to suffer from the fact that they feel they are not trusted by the family. They are also, it's not only a feeling, but they are not trusted by the family, and they are forced to continue treatment of the patients who do not have a chance to recover. Now, on the contrary, the family is very unhappy because they find themselves responsible and they think that they are obliged to fight for the life of their loved ones and not allow them to die. It will not be an easy job, but tailoring of care for the needs of the patients and family would be essential in the coming years. And we need to find a way to avoid regular conflicts and fulfill the needs of the patients and families from different cultures and religion, at the same time preventing the use of limited resources for patients without a chance for recovery. I would like to say a few words about the tolerance and permissiveness. If you look at the definition, tolerance is not something that we are agreeing with, but we tolerate it, even if we don't agree with it, even if we dislike it. Permissiveness, you don't have the dislike or disagree, but it is defined as allowing great and excessive freedom. When we are, for example, having a new medicine, it's a hell of a job. It takes years, even if everything is very successful. And at the end, maybe the medication or the method gets approval, but then that's not the end of the discussion, that's the beginning of the discussion. We have the situation that the new innovations may or may not be readily accepted, but there is permissiveness in medical world for one to express his opinion. The counter opinions are tolerated even if not agreed. We have roundtables, we have pro-con discussions, and this is one of the greatest strengths of the medical science. And I think we should never lose this tolerance and permissiveness in our profession. If you look to the world outside us, the tolerance and permissiveness is receiving a serious punch in our changing society. I could give a very easy example starting with climate, but I don't know anything about climate. Maybe you don't know also anything about climate, but I just say the name because that's one. But there are many other sorts of these things where pro-con is not tolerated. People with different opinions, even though they are backed with scientific evidence, are not brought together and permitted to have a nice discussion with each other. Congresses and articles contain certainly a view, but almost never a counter view. And counter view is the enemy. Important number of university directorates in the world are also following this view. Lecturers with opinions considered to be unsuitable are not welcome. It seems as if the rigid form of some of the religions seem to be haunting the science, which should be actually based on facts and not on feelings or beliefs. I want to take you back to 1985. This is an article published in New York Times. And it is about, with the title, let's say, The Permissive Dutch. The article has focused on many things at that time in the Netherlands, like protesting deployment of cruise missiles, legalizing of soft drugs, the rights of squatters, the crackers, the guaranteed lifetime support for everyone, etc., etc. But actually the article had a main theme, and that was the permissiveness of the Dutch society to allow these things to happen. The journalist was seeing these developments as permissiveness. The Prime Minister of that time, Ruud Lubbers, meant that it was tolerance. And his statement was, some people may call it permissive, some people may call it tolerant, but tolerance in itself is a good thing. If you let people express their differences, you will have less violence. The movement against tolerance and permissiveness is not limited to science. We see many other aspects which remain outside the scope of my talk, luckily. Nevertheless, in our present society, the direction we are heading, to phrase it as gently as possible, is the wrong direction. Looking a little bit at the future, I said the intensive care is a semi-autonomous mini-hospital. This will be University Medical Center Utrecht, Diederik as the head of the department. So what are our challenges in the future? Balancing the innovation with functionality, space availability, physical limitations and cost. We have been working for healing environment with safety and security for patients, family members and healthcare workers, and this was considered to be a luxury. I remember 7 years ago, I was giving a talk in the French Congress of Intensivists. When I presented my ICU and the concepts, the next speakers came to the microphone and said, now let's come back to the real world. This will be mandatory. We cannot escape it. This is not a luxury anymore. Patient data management systems primarily suitable for intensive care will also be mandatory. And not a little bit copy-paste systems, but real good systems for data access, audit, research and quality management. The precision medicine, we all talk about it, we are not there yet, but it will become a complementary to our randomized controlled trials to direct the right treatment to the right patient. We have already increased expectations from patients, from families, from physicians of other specialties. That will be even more prominent. Increasing the illnesses that are deemed treatable is a fact. We see that already trend. If you look at 25 years ago, what we could treat and what we are doing now, probably we have two different intensive cares which do not have anything to do with each other. So the demand of ICU care will rise exponentially. And one thing you cannot make me say, increase the ICU beds. Because if you say that, I will say first use it efficiently before you put another increase of 30–40%, because we are still not using our beds efficiently. First, we have to take care of that. And we need to expand our medium care facilities to take the burden from the ICU beds. But most importantly, instead of continuously looking for new drugs, expensive drugs, new interventions, and more money spending out, we have to do the simple things that we do every day better. It can be a tracheal suction, it can be cleaning the central venous catheter insertion point, it can be doing the selective digestive tract contamination in the mouth of the patient in a better way, but the simple things which we do daily. And there we have a lot to win, and not from 10,000 euro cost of medicine. I would like to summarize with the next few slides. During the 70 years of our enterprise, the intensive care medicine has reached to a very high level of clinical, educational, and research skills to improve patients' outcome and their quality of life after hospital discharge. So if we look back, we see an evolution of huge dimensions. The speed of the evolution is unfortunately not been the same everywhere, and we can't also expect it to be the same everywhere in the intensive care world. But there is a signal, and the signal given is very clear. Intensive care medicine is de facto a unique specialty and must be recognized as a medical specialty. It's maybe not necessary to say that we have come a long way since the polio epidemic in 1952, but we have still a long way to go in certain parts of the world to improve the intensive care medicine towards an outstanding organization in the medical care. During the last 43 years as a physician, I am honored to witness and humbly contribute to the enterprise and the dimensions of the evolution the intensive care medicine has made. Now, I'm having the most difficult job now because after 43 years in the profession, there is hardly anybody who says, I don't have anybody to thank. I have a lot of people to thank. I have my mentors, I have my colleagues, collaborators, people we work together. But there are so much that if I would be trying to give a name to all of them, we would probably stay here for another 45 minutes or more, and I won't do this to you. I would like, and of course, if you put all the names, you will always forget somebody. So I would like to make a general thank you to every single person who have been doing something with me, whether teaching me or collaborating with me, whatever. But there is one exception, and that's my wife, Hannah. We are together for 36 years, and with her love, with her patience, and with her support, I have been coming so far in front of you today. Ladies and gentlemen, my last slide. We need the vision. But you have seen, we have the vision. We know exactly what we want to be and to become. We have had a lot of difficulties behind us. It's not good to forget them, but you should not stick to them, because it has been always an inspiration to me. The Socrates 2,500 years ago, when he mentioned the secret to change is to focus all energy not on fighting the old, but on building the new. I don't know whether he meant what I think that he meant, but at least that's the sentence there. We have done things all the time, and for the future, I would like to say, let's walk it like we talk it. And I thank you very much that you have been patient on a Friday afternoon to listen to me for 45 minutes. I think it's now time to have a few drinks. Thank you very much.